Welcome to Health Focus, where we focus on your health. I'm your host, Dr. Scott. Today we're focusing on Mental Health Awareness Month. This is a really important topic to so many people, to their families of people who struggle with this, and to the community. And we're really very fortunate to have with us a distinguished guest, Dr. George Paz. Pleasure to have you here with us, Dr. Paz.
Thank you, Dr. Scott.
And I know that you're a psychiatrist who has an extensive background in terms of clinical experience. And so I think for this type of an awareness month, we really couldn't hope for a more qualified guest. So we're really delighted to have you here on the set.
Thank you.
And I understand you came to California by way of a kind of circuitous route, starting in New Mexico, where you initially went to college and received your medical training. Is that right?
That's right.
Tell us a little about that.
I grew up in New Mexico and went to college and medical school in Albuquerque, New Mexico. And then I moved to Los Angeles to do my internship and residency. And I lived there for quite a while, although I did move back to New Mexico to be on the faculty for a few years. So I've worked in private practice, academia, the VA, and most recently with Kaiser Permanente.
So you've seen mental health challenges in different settings, both in the civilian sector, in individuals who may have served in the military, and probably men and women all ages, I would imagine.
Yes, adolescents, beginning with adolescents. I'm not a child psychiatrist, but I did treat teenagers all the way up to geriatrics.
And that's very challenging, of course. And now we're becoming aware that, in fact, brain development can continue well into the 20s, particularly in areas related to the inhibition of behavior, the prefrontal cortex. So, without talking about adolescents as if they're just, anatomical entities, the fact is that you're different when you're an adolescent than when you're an adult. So that's a real challenge in so many ways, psychosocially and in every way.
That is very true. I think that teenagers at this time and place have particular challenges that maybe I or you did not have as we were growing up, with bullying and other social pressures. I think that has affected them greatly.
Well, let's talk a little bit about this particular Awareness Month. I understand that Mental Health Awareness Month actually began around the World War II era in the 1940s, and then it became so highly recognized that by the 1960s it was turned into a full awareness month. And now it's pretty well established. I believe it's always in the month of May, in fact. Are you very involved in the activities surrounding this, or familiar with it in your clinical experience?
Of course, mental health awareness is a big issue and always has been for me. I particularly feel that it's important to destigmatize mental health problems. I think people suffer doubly when they have a depression or problems with anxiety, but for them to seek treatment, there is that resistance that there must be something wrong with you, or you're morally not doing the right thing, or that you're weak emotionally, some reason why you're having that mental illness, when in fact it may be genetic. It may come from your parents and your ancestors. So becoming aware of mental illnesses, I think, is a big, important issue for me.
And certainly as a public health issue, we know that according to the National Institutes of Health and other reliable sources, that perhaps as many as 1 in 6 Americans have some kind of mental health issue. And if you do the math, that's going to be in excess of 50 million Americans. That's really an incredible public health concern, even in cases in which the issues might be a little bit more mild or situational and might not rise to the level of being really a health issue per se. Still, mental health is just a huge challenge for us as a nation, isn't it?
That's correct. If anything, mental diseases and mental illness is underreported. starting with seeing your primary care physician. If it's not picked up at that level, it may never rise to the level of being treated or addressed. So quite often, just for a person to complain may not even get you recognized unless somebody pays attention to the real signs and symptoms of a mental condition. So I think for the most part, mental diseases are underreported.
And I'm wondering if there are, in fact, even enough people who are trained in diagnosing and treating conditions related to the mind or the psyche, the mental health issues in general, to address concerns when you're talking about tens of millions of people. I mean, we just are going to have to rely not just on mental health providers, but also on other personnel, other people with other professional backgrounds, perhaps family and marriage counselors and people in the community with some counseling ability. I don't imagine there are enough psychiatrists to treat 50 million people, I would think, unless they see them only on a few occasions.
There is a shortage of mental health professionals, not only in California, although it is quite acute here in California, but all across the country. I don't think our prevalence rates are any particularly higher or lower. There are some industrialized countries that have higher rates. United States has higher rates than undeveloped countries. And there's always that question, is it a reporting issue, or is it that there is somehow some protective issues related to undeveloped countries where it's not, the condition doesn't manifest in inability to work when so many of the people are out of work. So quite often these epidemiological issues are still present at this day and age. But in terms of the workforce, I think we definitely are shorthanded.
I know that the medical anthropologist and psychiatrist Arthur Kleinman at Harvard looked at this. I, at one point, was in the field of medical anthropology as my area of interest and pursued graduate studies in that field. And I believe that Dr. Kleinman found that, for example, schizophrenia has a remarkably stable prevalence cross-culturally. It had been suggested that perhaps individuals who are schizophrenic really are just reacting to our cultural environment in a way in which they're labeled as having mental problems, but that perhaps in less technologically advanced societies that would not be the case. And if I remember correctly, Dr. Kleinman found that no, it's about 1% no matter where you go for schizophrenia. But as you point out, the implications might be different. If you're in a more rural or agrarian society with extended families and perhaps that kind of support network, perhaps it could be handled in a different way that isn't quite as disruptive to the community. I don't know. Does that make sense?
That is actually a lot of what's going on. Just taking the United States as, you know, where I've practiced and served, the social network is a little fragile. The families are a little bit more separated from one generation to the next, and even from parents to children. And so there isn't that kind of cohesion that would be helpful for people suffering from psychiatric illnesses. At the same time that I say that, I don't want families to feel like it's their fault that an individual is having problems, or that they are responsible for fixing the problem. I would rather that they understood that they need to get the help they need, and that would be how families could help, is by getting the person the help they need. So mostly I try to focus on destigmatizing mental problems with families, with patients, and in society as a whole.
Well, I hope we can get closer to eliminating that stigma, because I think you're absolutely right. And indeed, I understand only about 1 in 2 people in our country who have a mental condition that might benefit from treatment are actually being treated. So for whatever reason, it sounds like we still have quite a long ways to go.
That's correct.
And, let's get into it a little bit more, Dr. Paz, about the actual diagnoses. When we say mental health, and when we seek to foster and maintain mental health, we're not just talking about clinical disease states, we're talking about general well-being. So mental health, as I understand it, as a physician, it runs really sort of a spectrum from individuals who might be in perhaps what we might consider ideal health to those who are severely impaired. So, for example, when I worked in the state Department of State Hospitals, we talked about people who were unable to care for themselves, or perhaps even a threat to the community, grievously impaired due to mental illness. But then there are many people who have more minor problems, such as situational or reactive depression, grieving, anxiety, who are not mentally ill but are still suffering with mental health related issues. Could you cast a little more light on that? Do I have it about right?
That's very good in terms of helping people understand the full spectrum of conditions. And a particular diagnosis, say depression, for example, and we can talk about other conditions as well. Depression is the second most common illness. Anxiety is the most common. There's a lot of diagnosable anxiety disorders that never come to treatment. The same thing for depression. People have an attitude that depression, you should just be able to get over it. That you should just get out of bed, get to work, do what you need to do, and eventually your depression will go away. And there's a little truth in that, in the sense that people have that experience, that if there's something that knocks them down and they're able to get back up, they can start functioning again. Say, for example, grief. Grief is a normal reaction. People have grief when somebody dies, close member of their family. They may find themselves not being able to focus or do their work for about a week or two, but gradually have the experience of getting back to work. That is not even a diagnosis. Grief is almost a normal reaction. Where it gets to be a problem is 2, 3, 4 weeks later, the person is still in bed. They're still not functioning. They're still not able to take care of themselves or their families or whatever the situation is, do their studies, whatever. So then when we start talking about impairment, that's when we diagnose an illness. And so we have the experience in psychiatry where most of the patients do seek treatment first from a primary care physician. A doctor, if he is aware that this is a real depression, will start an antidepressant. About half the time, the person will respond, get better, and never see a psychiatrist. The other half the time, they continue to have depression, they don't get any better, and so they send them to us. So at that point, they're already a little bit like a month or two with depression, suffering. And so, and the longer it goes, in a way, the harder it gets to treat. I'm not saying see a psychiatrist the first day you get depressed, because nobody will probably recommend any kind of medication. But certainly a month, or certainly by the end of the second month, you do want to definitely get in to see a psychiatrist.
And how important is psychotherapy, cognitive or behavioral psychotherapy, as opposed to medication in managing these issues? I tend to think of mental health services, having been involved in mental health teams, as being a team approach. And I tend to think that a team approach is best. Do you have thoughts on that?
Yes. In just about every setting that I have worked, including private practice, I've worked with therapists, either psychologists or licensed clinical social workers, or marriage and family counselors. And so those professionals can oftentimes be the only treatment that's needed. Cognitive behavioral therapy, as you mentioned, is one of the proven therapies for quite a bit of depression, usually what we call mild to moderate depression. Moderate to severe depression, we are starting to think about medication. So and of course, in many situations, it's good to have both psychotherapy and medication. I always recommend that for my patients. See a therapist. You would be surprised how helpful that can be, just to talk about whatever problems you're having. But don't forget your medication at the same time.
Right. And with respect to both depression and anxiety, which you mentioned, do we have effective medications now that could really make a difference?
Yes, our medication regimens are much, much better. Starting in about the 50s, 1950s, with tricyclic antidepressants, we started to see major improvements in depression, all the way to being completely well, except for the question of whether the depression would recur. With SSRIs, we saw an even greater improvement, mainly in the fact that the SSRIs were considered safer and fewer side effects.
Excuse me if I may interrupt for a minute, Dr. Paz. So SSRIs are serotonin reuptake inhibitors.
That's correct.
What's the second S?
Selective serotonin.
Selective serotonin reuptake inhibitors.
And serotonin inhibitors are not the only kind of modern antidepressant. There are selective norepinephrine reuptake inhibitors, SNRIs. And then we have a whole range of what we call mood stabilizers that help antidepressants, that give antidepressants a boost, and also prevent the relapses, so that the antidepressants by themselves may not be enough, so we do use a combination.
Now, since you're talking about mood stabilizers, that would be agents like, I guess, Depakote would be one. Is that correct?
Depakote is a good one. We use that mainly for bipolar.
I was going to ask about bipolar.
Yes.
Now, bipolar, the modern term would be manic depressive disorder. Is that correct?
The older term is manic depressive.
Oh, the newer term is bipolar, yes.
The newer term is bipolar.
And you get this terminology from the sort of classical textbook, which is the Diagnostic and Statistical Manual. We're up to the, what, 5th edition now?
5th edition,
okay.
Yeah.
So do you feel optimistic about the treatment also for bipolar?
Yes.
Okay.
Bipolar has been able to be treated effectively starting with lithium and then progressing up to these anticonvulsant type mood stabilizers. That was another advance.
Right.
Anticonvulsants themselves have been around a long time, but it was only in the last, say, 20 years that we realized they're very effective as helping bipolar. And then the other conditions that are sort of overlapping with depression and bipolar, having to do with how often they relapse, things like that. Because sometimes they'll do fine with an initial antidepressant, then they'll have a relapse and they'll have to be treated with a mood stabilizer.
As a physician who's managed medical complications in psychiatric patients, I also should point out that there are side effects with these medicines.
That's right.
Lithium can cause a tremor. It can worsen skin conditions. The older tricyclic antidepressants can impair temperature regulation of the body. They could affect the rhythms of the heart. So all of these medications should be prescribed with careful discussion of the risks versus the benefits. I guess you would agree.
That's obvious. I always tell people that the reason we have psychiatry as a specialty is to manage side effects.
Unfortunately, we're not going to have enough time to discuss all aspects of psychiatry, or should I say mental health, which of course also involves clinical psychology, counselors, and I think exercise too, and nutrition.
Yes.
But Let's talk a little bit about the opioid epidemic. We don't have really enough time on that, but that's a mental health related issue, is it not?
That's correct. And as part of my practice, never prescribe opiates. I'm fortunate in that if a person has an opiate dependency, generally I refer to a chemical dependency program. But we do have medications that are very helpful at the detoxing of people so that they don't go through withdrawals, and also in preventing relapses for the opioid dependence. The opioid dependence is sort of a reaction to an initial complaint that patients were having, and people in politics were complaining that doctors weren't doing enough. So there was a lot of efforts to get people to prescribe as much as it took. A lot of these were cancer patients, but give them whatever they needed. Well, we've subsequently learned that that's not a good idea. You have to eventually get them off of it, and that's when you notice the dependence and the addiction.
I think the pendulum swung too far towards overprescribing, and it's beginning to swing back. So
Exactly.
I think that's what we're dealing with. How about other forms of addictive behavior, alcohol and cigarette use, for example, or illicit drugs? As a psychiatrist, can you help people with that, or do you generally refer them to specific addiction treatment centers?
I oftentimes discuss alcohol use with my patients. I, of course, want people to quit smoking, and I can prescribe for that. Chantix helps with the cravings, and the nicotine patches help with the withdrawal symptoms. So the combination of a patch and Chantix are often very effective. That's for smoking. For alcohol, I do refer to, if that is an issue, patients will sometimes not admit to it initially, but if it turns out that that's interfering with their depression for, say, underlying treatment or anxiety, I will have to refer them to a substance abuse program.
And of course, I'm sure in your experience at the VA dealing with post-traumatic stress disorder, you've observed that these things tend to go together. If a person has a mental challenge and alcohol and drug use is involved, it just makes it that much worse. So obviously you have to look at this holistically. Any thoughts on, just briefly, on support for caregivers and family members? Are there resources out there in the community for that?
Yes. Oftentimes families need to support the individual that is suffering. And just off the top of my head, there's NAMI for bipolar patients. It's completely family member run and provides support for the family members. Of course, North Bay offers a number of support groups for bereavement, people that are terminally ill, and Kaiser, all of the medical providers will be able to give you some support while you're helping the loved one who is sick and either terminally ill or has passed or whatever.
And in terms of fostering good mental health in all of us, what steps can we take as a community to just prevent mental health issues from arising and to just foster good health as we go into this awareness month?
I like to think of good mental health as being supportive of one another. And if a person is suffering and they're having problems with their mood, help them to get help. Yes, a word of advice is often very helpful, and they shouldn't be encouraging. They should also be trying to figure out what's causing the depression or anxiety.
Right.
Bullying is a big problem these days, so parents pretty much are smart about that.
Right.
They know about that and ask about that, but it's still very hard for the child to admit it or ask for help for that. So, but be available, be aware, try and help your adolescent children. And that goes all the way up through the life cycle. If you see somebody struggling, encourage them to get help.
And of course, we didn't really get into suicide prevention, but probably there's nothing more important that you do in psychiatry. And obviously, We have all been moved and really distraught over particularly teenage suicide, and that's an area that really deserves the support of the community in terms of further research and further efforts on an individual level to prevent these issues. We now know that you really want to talk to people and not maintain this silence around this area.
That is correct.
Do you have any thoughts in terms of the future of mental health prevention? Do you think the future looks bright? Do you feel research is moving us in a better direction?
I have a lot of optimism that we will have the same kinds of success in psychiatry and all the mental diseases and disorders that we have with other illnesses. Understand that a lot of the diseases that we deal with are very chronic, like diabetes or high blood pressure, and so it takes a constant attention to the dealing with the problems. But yes, I feel we can offer a good amount of treatment now, provided that people seek the treatment that they need.
Dr. George Paz, it's been really a pleasure to have you here on Health Focus.
Thank you very much.
And I want to thank you also for your service to the community as a psychiatrist. And I also want to recognize the service of so many other people in the mental health related field, clinical psychologists, social workers, marriage and family counselors, psychiatric technicians, and for that matter, people who just provide support as caregivers and for nutrition, for exercise, for the needs of daily life to individuals who are wrestling with these problems. And I think that focusing on this awareness month for mental health has been really important. I wish we had more time than just a half an hour because it really does, qualifies for more time. But come back and see us again here on Health Focus.
I will. Thank you for providing this opportunity.
It's been our pleasure. Remember, here on Health Focus, we focus on your health. I'm Dr. Scott, your host, and it's really been a pleasure to talk to you today a little bit with our distinguished guest about National Mental Health Awareness Month. And we are wishing all of you the best of health until next time. Thank you for joining us.